Hello, everyone. Welcome back to another episode of the Tokyo Living Podcast Injury Edition. Today, we're going to be discussing ankle sprains or ankle injuries, acute ankle injuries in general. Ankle injuries are extremely common. We know that in about 33% of all sports that have a decent amount of statistics on them, probably about 70 or so sports, that the ankle is the most commonly injured area of the body. A lot of people listening or watching will have experienced this type of injury in the past, but they're also an injury category that is often mismanaged and undermanaged. And I think part of this relates to how common the injury is and the thought that an ankle sprain is a fairly simple injury to manage. And as a result of this, we often have long-term issues associated with ankle injuries, both in terms of long-term pain after the initial episode, but also recurrent ankle sprains. So we'll talk a little bit about why this occurs and what we can potentially do to optimize our management to improve long-term outcomes. So when we look at acute ankle injuries, by far the most common mechanism of injury is a rolling inwards of the foot. So foot basically turns in towards the opposite foot, and basically the rest of the leg is moved outwards. We can see the opposite mechanism where we go with the foot turning outwards, where we stretch the structures on the inside. But that's far less common. When we're moving the foot inwards, it is what we call an inversion sprain. We're essentially causing damage to the ligaments on the outside of the ankle. Now, a ligament, as a review, is a structure that connects bone to bone. So it's, I guess, what most people think of its primary function, and it is its primary function, is to check the movement between those two bones and make sure that those bones don't move too far away from each other. And so in case of an ankle sprain, they do move too far away from each other and they cause a certain amount of damage to that ligament. And on the outside of the ankle, there are three ligaments, one sort of straight down the center, one to the front, and one to the back. The one at the front, which we call the anterior talofibular ligament, which is basically attaching the foot to the fibula, which is the outside bone of the ankle. We'll call this the ATFL for short. That one is most commonly injured. It's when we cause an ankle sprain, we're often in a slight downward position of the foot. So the foot is what we call in plantar flexion. And so that puts more stress on that ligament at the front. In some cases, we have damage, and especially when the ankle sprain is more severe. Again, when the bones move a little bit further away from each other, we do get damage to the calcaneofibular ligament, which is the one right down the center, the CFL. And then the one at the back is more if we're sort of forced with the foot bent back towards us at the time of the sprain, and that is the least common of those. When we get a lengthening of the ligaments, we get tearing of some of those fibers. So when we have tearing of fibers, we oftentimes experience pain, depending on all the other factors that go into a painful experience. And we will typically experience quite a large degree of swelling. The ankle probably swells up more than most other ligamentous or soft tissue injuries. It's a highly vascularized area, and most people will report that their ankle blew up the size of a balloon. And so essentially that's what's happening in our basic ankle sprain mechanism. Now, the opposite movement where the foot moves outwards, what we call an eversion sprain, doesn't happen nearly as frequently. The ligaments on the inside of the ankle are a lot stronger, and just the way that the ankle joint is configured. Obviously, if you imagine how you look at your own foot, it's a very complicated structure. There's a lot of bones going on there. And because our body doesn't work around a completely straight up and down axis, there's a lot of rotation and sideways movement and rotational movement that's involved in every movement in our body. But the joint of the ankle has to be structured in a way to allow that. So it's asymmetrical. And because of that asymmetrical structure, it's easier for the bones to move in that inversion direction with the foot moving inwards. So stronger ligaments and a bony structure that cause the ligaments on the inside to be less frequently injured. However, when they are injured, they do take a lot longer longer to heal. So the first thing to note is if you have an ankle sprain that's in the opposite to a normal ankle sprain, you're looking at a much longer rehab process. And the medical practitioner that's guiding you through this process needs to be aware of that and needs to set realistic expectations. So most people, when they experience an ankle sprain, they have that sensation of a massive amount of swelling and pain and difficulty walking. A lot of people will basically, hobble around on it, maybe put some ice on it, maybe do some compression and some elevation, as is by the typical sort of RISA or police, whatever sort of guidelines you want to use, just trying to take some weight off it and allow that pain to settle down. And then people will often just wait for the pain to settle down and ease back into activity. In more severe cases, if there is concern over further damage, you might go down the route of imaging. So an X-ray or perhaps an MRI. In terms of an X-ray, we have some pretty specific guidelines about when we do X-ray an ankle. If an ankle presents to our clinic, we note their initial ability to weight bear for a number of steps, and we feel along certain areas of the ankle where a fracture is likely to take place. And if there is a certain amount of tenderness around these areas, then that is a guideline to refer to an X-ray. If those tests come back negative, then it's very, very unlikely that there'll be a fracture there. So the X-ray is essentially a waste of time and resources and radiation exposure. However, if they are unable to weight bear and sense and they are tender to touch around that area, then there is a high likelihood of a fracture. So we need to have that person X-ray, as a fracture. The evidence of a fracture will dramatically change our management strategy. So that's the first thing to consider in terms of imaging and initial management. The MRI is probably not as important early on. If you're working in a high-level sporting environment, they may want to MRI to assess the degree of ligamentous damage occurring, because that will set a prognosis for return to sport. But for most people, we go through a clinical exam, and we're basing our grading of the ligamentous damage based on our clinical tests. So we can observe how much laxity we're feeling, how much additional movement there is in comparison to the other side, and then grading that accordingly. That does become a little more complicated in the case of someone who has had multiple ankle sprains. And if someone has a high degree of general body laxity and they've played a lot of sport, it's quite likely that they've had several ankle sprains on both sides. And so then it becomes a little bit more difficult in terms of the clinical judgment, and we just need to use our best clinical judgment to make an assessment of the degree of ankle ligamentous damage there. So that management plan of allowing the pain to settle and then easing back into activity, why is that sometimes unsuccessful? There's a few factors that go into this. So generally, after an ankle sprain occurs, we observe several ongoing changes to the function in our body. The first of those is a range of motion deficit, and particularly in the forwards and backwards plane. So we call dorsiflexion and plantarflexion, especially the dorsiflexion. So imagine bending the toes back up towards you. This movement is limited. And as that movement becomes limited, as we then go back into our normal function, whether it be sports or day-to-day function, the limitation in that range then puts more pressure on other areas of the ankle that then start to become sensitized and potentially start to cause pain. It can also cause stress in other areas of the body. So it's not uncommon after an ankle sprain for someone to then go on to develop secondary knee pain. So it is important that we restore that ankle range of motion as soon as possible. The second impairment is one of strength. So this happens in a lot of areas of the body. After we have an injury, we have a decrease in the force output of the body. The central nervous system is basically guarding, it's putting brakes on and not allowing us to apply the necessary amount of force. And over time, this leads to a decrease in the ability of the system to generate force. As with any area of the body, if we have a decrease in strength or power, endurance, or whatever capacity it is, that will put pressure on that particular joint and other joints in the body, same as with range of motion, and potentially increase the likelihood of further injury to that joint or other joints in the body. Probably the most important change that happens after an ankle ligament sprain is a decrease in what we call proprioception. So essentially, proprioception refers to our brain's ability to sense the position of a certain joint. So if I move my finger, if you're watching the video version of this, I move my finger from here to here, I should have a pretty good representation of that exact movement as it's occurring and where it's occurring. And how do we do this? Obviously, if I'm closing my eyes and moving, I can't see where the foot, whether my finger is. And the same, if I move my ankle and I'm not looking at the joint, I can't see it. We need to know, we should have an inherent sense of where that joint is positioned in space. Now, at the top, I talked about ligaments and their main role as being one of checking the movement between two bones. So if two bones move away from each other, the ligament becomes taut and it provides some structural support. The other really important function that ligaments have, along with other structures in the body, but they basically have inbuilt sensors that tell us about the amount of stretch that's been caused in those structures. So if our ligaments lengthen to a certain point, our brain should be able to sense how much that ligament is lengthening, and that would provide some of the information that allows us to know where our joint is in space. What we've observed, a lot of people intuitively think that if you step out onto the foot and the ankle rolls, that ankle roll has occurred after you put your foot down to the ground. And that's what's causing the sprain after that. What we know through research is that the ankle roll has actually started to occur before you even put the foot down. We know this from video footage of, particularly in professional sport, where we obviously have quite detailed and video footage from a lot of different angles, and we're going to see exactly what the body's doing in and around the point of an injury. And so we know that when someone sprains their ankle, that ankle is in a suboptimal position before hitting the ground. So you're already setting yourself up for that sprain while the foot is in the air. And as the foot makes contact with the ground, because it's not in that optimal position, it rolls over. And that's maybe combined with the fact that you're not strong enough to prevent that further rolling occurring as the foot hits the ground. And then it goes into that position, that inversion position, and we get, if in the case of a recurrent sprain, further damage to that ligament. So after damage to a ligament, not only is the structural integrity a little bit suboptimal, so the ligament is now a little bit longer, so it's not providing as much structural stability, but that sensor system has now been impaired. So the messages that the ligament is giving back to the brain are no longer quite as accurate as they could be or were. And so the brain's ability to put that ankle in the optimal position prior to the contact with the ground is now impaired. And obviously you can understand how that would set us up for further injury. So how do these factors influence our rehab? First of all, the initial management strategy is one of trying to decrease pain. So this is really important for a number of reasons. One is the quicker we can decrease pain, the quicker that we can start getting someone moving and mobilizing the ankle. This helps in a number of different ways. First of all, it helps decrease the sensitivity of the joint. If we stay off an injured body part for too long, basically the longer we stay off it, the more chance there is for us to develop hypersensitivity and just increase sensitivity around those structures. Those we talked about in a previous episode, nociceptors, those signals around the injured area that are giving our brain those threat sort of warnings, they might be upregulated. So we're going to get a little bit more sensitivity. We also become stiffer. So the longer we're off our ankle, the stiffer the ankle becomes. And we talked about how that's problematic. And the same thing with strength. The longer we're off the ankle, the more chance there is for those muscles to become deconditioned, and the longer it will take for us to build that strength back up. The longer the swelling remains, that can become problematic as well, because the swelling can lead to increased sensitivity, and the swelling can also lead to a decreased range of motion. So we do want to decrease pain and swelling as quick as possible. The other thing that's really important is getting loading through those ligaments. So this is probably one of the hardest things for people to understand, is that in order for a structure to heal, it needs load. Load is key. Too much load, and we can obviously keep a structure sensitized and slow down the healing process. But if we don't get enough load, then we're not optimizing that healing process. We call this a whole mechanism, mechanotransduction. We talked about this in the last episode when we talked about tendons, but it's the same with ligaments. So the earlier we can get an appropriate amount of load on those ligaments, the better the ligaments become at realigning those fibers. They heal with a more optimal type of scar tissue, because we're never going to get the same type of tissue reforming, but we can get as close as possible to that original tissue by developing good quality scar tissue around the ligament, and early movement and early loading is key for this. And the earlier we can realign those fibers and get the ligament as normal as possible, the more we're maintaining that sensor mechanism, that feedback that we need from those ligaments to provide us with good information about the joint position sense and optimizing our proprioceptive system. So how do we do this? Some of the modalities that we talked about before are good. So we need relative rest and elevation. You don't want to go loading at day one. If it's really painful and really swollen, we do need a little bit of time with the foot up on the couch, elevated, allowing some of that swelling to drain out. And so the compression can be useful in this stage as well. Ice is a difficult one. In the rehab world, we're sort of moving away from ice a little bit now in a lot of instances. We know that it may impair the healing process. And certainly for soft tissue injuries, we're seeing it's probably not the optimal first-line strategy. It can be very useful later on to modulate pain and allow some decreases in pain and allow us a window of opportunity to exercise. But early on, we actually want to use that inflammatory process to aid in the healing process. With ankles, however, I'm not convinced that ice isn't the best strategy. Basically, the inflammatory process associated with an ankle sprain is almost excessive. So we're creating more inflammation, as we talked about before. It's one of those joints that just blows up like a balloon. And anecdotally, we have seen that ice can be effective in controlling that. So I think that as long as we're not overdoing the ice, for the ankle at least, I'm still, and this might change within the next 6 months, but I'm still of the mindset that it can be useful. And probably the main reason for this is that it can have a big analgesic effect. So whilst there may be like a small effect of the ice actually impairing the healing process, if the ice substantially decreases our pain and allows us to get walking and get moving earlier, that will actually help with the healing process long term, because we're getting that early loading. And we also know that the early movement can help with the inflammation. So along that path, if we can do some other types of movements, say swimming or even cycling, just something to keep the body moving, that can really help with the inflammation as well. Early on, we start with some very basic range of motion exercises, and these are pretty lame sort of movements that don't feel like you're doing much, but you are actually getting some movement of that inflammation. You're sort of trying to flush some of that swelling back into the system, and that can be really useful. The other thing that we like doing early on is some practice of range of motion work with some specific joint position sense exercises. So maybe putting the foot in one position and then try and match that position with the other foot and start to retrain that proprioception system very early. I think traditionally with ankle sprain rehab, we would think of proprioception as maybe something to start later on and standing on unbalanced surfaces and colourful toys and things like that, which does have its place. But we can actually start the proprioception retraining very early on. So from day one, just practicing moving the foot and having a good sense of where that foot is in space. From there, once we can load, we start a graded loading of walking and just making sure that whatever we're doing doesn't increase the symptoms afterwards, and progressing from walking to jogging to running and progress and basing that progression on a consistent decrease in pain and swelling. Anytime the pain and swelling increases, we need to regress that graded loading protocol, and then progressing that through to to whatever level of function that individual needs to return to. At the same time, we progress our strengthening work. So we need to make sure that we get our strength on that side as close to the other side as possible. And likewise for range of motion, we don't want to go back to full activity if there are major strength and range of motion restrictions remaining. So we progress our strength and progress that to whatever level that individual needs to return to function. And then we progress our proprioception training. And it's important that we progress our proprioception training through a full range of motion. So in the past, we used to sort of focus on having a very stable ankle, so standing on an unbalanced surface, but trying to limit the amount of movement at the ankle. Now we sort of tend to go the opposite. So once a person is safe to do so and they don't have pain with stretch of the ligaments, we want to actually take those ligaments through that full range of motion, move the ankle through a full range of motion, expose it to a large variety of movement, so that we're stressing the ligaments. Again, we're continuing to improve the load tolerance of the ligaments, their ability to stretch and provide tensile support to the bones under load, but also retrain that proprioception system, making sure that at all angles of the ankle, try saying that 10 times, we're getting good information back to the brain and therefore developing that ability to control the foot's position in space. And then sort of building back up to hopping and jumping and those sort of tasks to really stress the ankle out and make sure that it can tolerate those sort of movements. Unfortunately, we know that around 30 to 50% of ankle sprains do go on to develop what we call chronic ankle instability, when we have ongoing ankle sprains or a level of instability that impacts our ongoing function. So there are some basic factors that may cause a person to have ongoing issues with the ankle. So impaired proprioception, impaired strength, and impaired range of motion. And then maybe also suboptimal initial management that led to suboptimal healing of those ligaments. We can have what we call a complex ankle injury, which is just basically an injury that doesn't respond to the normal ankle sprain management. And often if things like range of motion, strength, and proprioception have been addressed, then it may be more of a bigger structural issue that is causing the problem. The first one is what we call the syndesmosis. So the syndesmosis is a group of ligaments that basically stabilizes the tibia and the fibula, the two shin bones together, and by doing so creates, that gap for the foot to fit in and form the ankle joint. We can get a syndesmosis sprain occurring at the same time as an ankle sprain. And depending on what you read, we think that that's probably occurring in even up to 20% of more serious ankle sprains. That can cause pain locally in the area, what we call a high ankle sprain related pain. So that the pain is actually higher up than the normal ankle sprain, but it can also cause ongoing issues with the ankle itself. So if we have a syndesmosis sprain that's caused a little bit bigger gap between those two shin bones, then that actually puts more stress on the ankle ligament. So it can cause secondary ligamentous issues. So one investigation that we might want to go down, if someone is having prolonged ankle pain after a sprain, is having a look at the syndesmosis, either by MRI or by an X-ray. An X-ray should be able to tell us the amount of gap between those two bones and therefore the amount of syndesmotic damage. If we have an ankle sprain that's associated with a lot of rotation outwards of the ankle, then we're probably looking at that a little early on, as part of our initial investigation to see whether there is syndesmosis involvement. And in particular, if someone is having pain up a little bit higher than the normal ankle joint sprain pain area, then we would look at that as well. We also have the talar dome. So the talus is the sort of top part of the foot. The foot is made up of essentially, or the hind foot, the back is made up of two bones, a talus and a calcaneus. And the talus joins with the tibia, with the fibula coming down the side to form the ankle joint. That talar dome, especially if there's an element of compression in the injury, so perhaps if someone fell from a height associated with the ankle sprain, we can get some damage there. It's thought that even up to 90% of severe ankles, or moderate to severe ankle sprains, actually have some degree of talar dome contusion or bruising. We can also have the osteochondral defect, so an actual tear in the cartilage of the ankle. These ones are interesting in that they initially progress quite well, but then start to get a little worse. If someone is presenting that way, that they are doing well early on, but then they get worse, then this would be an indication for MRI to see if this area is impacted. This does have a fairly poor blood supply, poor ability to regenerate naturally, and this is another area that may require surgical intervention. As with the syndesmosis, if there's a large degree of instability associated with the syndesmosis, both of these might require surgical intervention. Fractures, someone is having trouble weight bearing, we would send them for an X-ray, and that will tend to identify the major type of ankle fractures. However, there are smaller fractures around the area that aren't always identified on an X-ray. So if the ankle is progressing slowly, an MRI might be required to detect some of these fractures, which may require either a period of non-weight bearing or in some cases, again, surgical intervention. There's some tendon issues. So in particular, with an inversion sprain, we have the peroneal tendons, which sort of muscles that run down the outside of the foot, and they can become involved as well. And so we're treating that basically as a tendon injury, which will require a slightly different course of management. And we can have issues with the sinus tarsi. So the sinus tarsi is essentially like a tunnel between those two bones of the foot that we talked about before, the calcaneus and the talus. And that can be prone to inflammation after an ankle sprain, or if someone has excessive movement through that subtalar joint, the joint between those two bones. And so this needs to be managed in some cases with a little bit more of an anti-inflammatory approach. So perhaps a corticosteroid injection to try and settle down the inflammation there. We can also have some generalized synovitis where the joints become sort of inflamed. And again, that, like sinus tarsi inflammation, may require a little bit more of an anti-inflammatory approach if it isn't responding to the normal approach of graded loading. And then we can also have chronic regional pain syndrome. So this is where we talked before about the system becoming excessively sensitive. And CRPS is basically where this becomes to a much, much greater degree. So the central nervous system becomes hypersensitive. And at that stage, our normal musculoskeletal approach to an ankle injury becomes not particularly useful. So we need to take a much different approach and need to work on specific techniques to try and decrease the sensitivity of the nervous system and decrease the sensitivity of the local peripheral nerves. So that will require a more specialized approach. So again, if an ankle sprain pain is lasting much longer than we would expect, especially in children, we do see this CRPS occur, especially in juvenile patients. So if we have a young patient that is either not progressing or getting worse after an ankle sprain, we will be looking at this as a potential diagnosis. So that's just a basic recap of ankle sprain. I'm trying to keep these episodes a little bit shorter. Failed fairly miserably there, but I hope that has been of use to people. It is really important. The underlying message is that an ankle sprain is rarely just a simple ankle sprain. And whilst the pain might get better and you might be able to return to function, there is a high likelihood that you may have ongoing issues or you may have a risk of re-injury. We know from a fairly large study that rehab does decrease the risk of re-injury by about 50%, but it needs to be undertaken for a certain amount of time. So you need to be giving an ankle rehab program at least 6 months. Now that's not an hour 3 times a week of rehab. It might just be a small amount of ongoing exercise and maintenance work, but it does make a big difference. And especially if you are playing a lot of sport, you don't want to be out for an ankle sprain that keeps you out for 3 or 4 weeks, every 6 months. You want to try and get on top of that and minimize the risk of re-injury. So I hope that's of interest to people. If you have had an ankle injury and you would like some guidance, get in contact with us. If you're in the Tokyo area, obviously come and see us. And if you do have other topics that you would like me to speak about, please let me know. Thanks for listening. Thanks for watching. And we'll see you on the next episode.